I think the field of CML is very exciting. We have many very effective drugs. I think most CML clinicians are very excited about the potential for therapies coming along. One of them that looks very promising is asciminib, also called ABL001, which is a Novartis drug, which is also inhibits the ABL kinase, but does it by a different mechanism to the current tyrosine kinase inhibitors. And it seems to have much lower toxicity for an equivalent amount of potency, which I think is a very exciting message for patients. Clearly we need a lot more information. At the moment we just have a phase 1 trial, but we're now going into phase 2 and phase 3 trials, and I think look forward to this drug coming along in the next 5 years or so as a next step in the progress of getting CML even better and better managed than we have today. There are other promising drugs that we're looking at that can be added to the TKIs, but at this stage most of that clinical trial data is fairly early, and it's hard to know which are going to be the winners there. I think most CML clinicians are changing their view about CML. Over the last 10-15 years, we've looked at it as a disease that we need to control long term. Just like hypertension or diabetes, it needs ongoing therapy, year on, and the focus needs to be minimizing the toxicity of the therapy. But I think with the accumulating evidence from the treatment-free remission studies, increasingly we see the potential that our therapy for CML is not just lifelong therapy, but it's therapy to get us to an endpoint, and that is to achieve treatment-free remission. And I think the majority of patients will be able to achieve that over the next decade as we improve our strategies for achieving a deep response and improve our capacity to predict the patients who can stop safely.